Thank you, Colette. This is Emily Ellman, and I am a Senior Policy Analyst with the Reproductive Health Program in the Public Health Division of the Oregon Health Authority, and I am joined remotely by my colleague Leslie Ubel, and together we will be talking to you all about reproductive health services in Oregon and some of the recent changes that occurred due to recent legislation that have really expanded access to coverage for reproductive health services. So I'm going to start with, let's see, let me make sure I can advance the slides. Good. I'm going to start by talking about some of these changes due to legislation and some of the key components of that legislation. And then I'm going to kind of pull it back and talk a little bit about reproductive health services in Oregon more broadly. And then what we really want to do is spend the rest of the presentation, and this is where Leslie will take over, really kind of trying to give you the resources and information that you need to know to assist clients and community members in accessing reproductive health services. And then we want to hear from you as we kind of continue to roll out the expansion of services. We would really want to ensure that we're being responsive to both community members and providers and community partners. So let's go ahead and get started. I want to lay the foundation a little bit about reproductive health in Oregon. Oregon is really lucky to have and has always had a really supportive climate for reproductive health access for all Oregonians. Because of sort of the way healthcare is structured, and I'm sure you all are familiar with this, it's somewhat of a patchwork. So there are multiple programs and coverage sources that support the provision of reproductive health services in Oregon. So we'll spend a little bit of time in this presentation talking about the work we do in the reproductive health program. Of course, the Oregon Health Plan has and continues to offer or cover a full range of reproductive health services. We'll talk a little bit about some of the services that have been available under Cowan Plus and that will be expanded, and an additional service that's sort of being added to the Cowan package. And then, of course, private insurance. So really, I think it's important to know that, or to remember that that there's a patchwork of coverage, and it can be fragmented at times, but really there is great coverage for reproductive health services. And the coverage was greatly expanded in 2017. The Reproductive Health Equity Act was signed into law by Governor Brown in the summer of 2017, and there was a lot of media attention around this. A lot of it centered around abortion, which is certainly a component of the bill. As you'll see, the bill is pretty expansive, and it really is considered one of the most progressive pieces of legislation around reproductive health in the country. Some of you may sort of be familiar with this information. We've been kind of doing a road show with it, trying to get this information out to as many people as possible. And you may have participated in December's Provider Collaborative webinar, so I apologize if this is somewhat duplicative, but so I'll go over it fairly quickly. As I mentioned, the Reproductive Health Equity Act was a big bill, lots of components to it. One of the main components is that it requires private health benefit plans regulated in the state of Oregon to cover a full range of reproductive health preventative services, including abortion and vasectomy. And this was really an attempt to codify at the state level the coverage of preventative health, reproductive health services without any cost sharing, regardless of any changes that would happen at the federal level around ACA. So in a lot of ways, this really sort of ensures that the preventative health services coverage requirements that were put into place with the passage of ACA remain in place in Oregon, regardless of what happens at the federal level. This requirement will go into effect January 1st of 2019. I do want to make note that it goes a little bit above and beyond the ACA preventative services coverage requirements by including abortion with no cost sharing and male sterilization or vasectomy. So vasectomy was not included obviously in the women's preventative health services coverage requirements as the ACA, but I think there was strong recognition by the crafters of this bill that vasectomy is a highly effective method of birth control, and so this was added as a required covered service. The next piece of the bill, which when it became effective upon passage, so it sort of immediately became effective, is the prohibition of private health insurers from discriminating against or denying benefits on the basis of gender identity, sexual orientation, disability, age, national origin, sex, and race. So it really ensures that anyone who needs to access services regardless of their gender identity, so this is including trans folks, gender non-conforming individuals, have access to the services that they need. This next piece was also effective upon passage, and it codifies the right to provide and receive an abortion in the state. So again, this, like the first requirement of private insurers, was an attempt to kind of codify into state law the legal right to an abortion, regardless of what may happen at the federal level. I'm going to move into now the components of the bill that OHA is responsible for implementing. And I'm going to go into more detail on each of the pieces of this slide. So I won't spend a lot of time on this slide, but as of April 1st, so a week ago, any individual enrolled in Cowan Plus now has access to full medical coverage for 60 days postpartum. And the second piece on this slide ensures or provides coverage for a full range of reproductive health services for individuals who are able to become pregnant and who would be eligible for medical assistance if not for their immigration status. So that's definitely a mouthful, and so we will delve into that a little bit more a little bit later in the presentation. Okay, so let's spend some time talking about the Cowan Plus 60-day postpartum extension. So this is coverage, again, that began April 1st. It is essentially an extension of full medical care, including dental. So I want to make that clear. We've had some questions over the past week about what that coverage includes, and it does include dental. And it's extended for 60 days regardless of how the pregnancy ends. In addition to full medical care, it includes immediate postpartum voluntary female sterilization, so that means tubal ligation provided immediately post-delivery. It also includes immediate postpartum LARC insertion. So for those of you who may not be familiar with the term LARC, it's long-acting reversible contraception. So this includes the implant and IUD. providers serving women in the postpartum period, in the 60-day postpartum period, should bill OH fee for service for these services in the same way that services provided in the prenatal period for women enrolled in Cowan Bless are billed. I want to make a note or a reminder that for female sterilizations, regardless of whether they're occurring immediately postpartum or outside of the postpartum period, sterilization consent form is required to be signed at least 30 days prior to the procedure. So this means that providers will definitely want to be talking about women's options for postpartum contraception, in the prenatal period, and ensuring that if a woman chooses female sterilization as her method, that consent form is signed at least 30 days prior to expected delivery. So you want to make sure to give yourself lots of time.
And we have a quick question.
Sure.
It mentions immediate placement of LARC, but this would be available through the 60-day period of coverage, correct?
That is correct, and we will be talking a little bit about the benefits, including LARCs, for women who are not in a 60-day postpartum period. But this is true that any contraception provided within the 60-day postpartum period is kind of covered through this benefit. I hope that answers your question. If not, feel free to type in kind of some clarification, and I'll make sure to answer what you're asking. So after the 60-day period ends, coverage reverts back to Cowan after the 60-day postpartum period if the client is still income eligible. So actually, I'm going to pause here in case there are more questions. This is my cat, Mango. In the previous provider collaborative, I featured one of my other cats, and I felt like Mango needed to get some screen time. So that's Mango, who sleeps wherever and whenever he can. Do we have any additional questions at this point?
Just a comment that is an adorable kitty.
Oh, well, thank you. I think so too. Okay.
Oh, another question. Is there any way to see an MMIS when the 60-day period is over, or simply must check each day to see if the patient is eligible? So Mary, it really should be 60 days from when the pregnancy ends, but as you know, the MMIS provider web portal just shows the coverage for the date of service that you're checking, so the day of. It doesn't show future eligibility.
And I see we have another question that is, what if at delivery they decide sterilization? Could they not then use the extended 60-day coverage for this, which would allow the 30 days to sign the consent form? Yes, so as we'll talk a little bit in the next slide, coverage for these women, including female sterilization, can occur after the 60-day postpartum period. It's through kind of a slightly different mechanism. And to be honest, I'm not a clinician, and so I don't want to make any sort of recommendations about clinical practice around when it's best practice to provide a tubal after sort of within the postpartum period. But please do know that there is coverage within the 60-day coverage period for female sterilization and beyond. And I'll get to the beyond part in the next slide. Okay, so I'm going to keep going. So, I guess I kind of want to say, and I should have maybe said this at the beginning of the slides, is that the benefits that were defined in the Reproductive Health Equity Act and that OHA is responsible for administering kind of fall to two different divisions or under two different divisions within the Oregon Health Authority. And the expansion of Cowan Plus into the 60-day postpartum period and the services on this slide, which I'll go over in just a minute, fall under the Health Systems Division, which is the division that administers OHP, Cowan, and Cowan Plus. The other services, which I will be discussing in the subsequent slides, fall under the Reproductive Health Program in the Public Health Division. And so we recognize that it's a little bit fragmented, and we want to, and knowing that women sort of move from different kind of throughout their life course having different needs, healthcare needs, they might fall under the Cowan Plus benefit package during the prenatal period and immediate postpartum period. And then they might fall to other preventative reproductive health services outside of that perinatal period, and that would sort of fall under the reproductive health program purview. And so we'll get to those services in just a minute, but I wanted to stay with the Cowan and Cowan Plus piece for just another minute longer. So individuals who are interested in female sterilization kind of outside of that postpartum period, so either beyond the 60-day postpartum period or at any point in their reproductive health lives, can access the service. They must be enrolled in Cowan, which means completing the OHP application, and once they are enrolled in the Cowan benefit package, they can access voluntary female sterilization. It should be noted that this service, unlike the other emergency-based services that Cowan most generally covers, is not federally funded. This service is really part of the Reproductive Health Equity Act. For women that are in need of an inpatient abortion service, so this is really a scenario in which a woman needs to be admitted to the hospital. This could occur if later gestational age due to a fetal anomaly, really where the level of care needed is beyond what an outpatient clinic could provide. The individual would need to, if not already, be enrolled in Cowan Plus. And for both of these services, providers should bill OHA fee-for-service in the same way that they do for other Cowan and Cowan Plus services provided. And I want to stop here because I know sometimes this can be a bit tricky, and I want to see if there are any questions. No? Okay. So now I'm going to kind of, as I mentioned, how this bill and the pieces that OHA is responsible for administering kind of falls between the Health Systems Division and the Public Health Division. I'm going to kind of move over to the coverage being administered in the Reproductive Health Program within the Public Health Division. And I'm going to start by kind of reading out the language, and this is taken pretty much word for word from the bill itself, but it really defines who the eligible population is for the services outlined in the bill. And it's coverage for a full range of reproductive health services for individuals who are able to become pregnant and who would be eligible for medical assistance if not for their immigration status. So that includes individuals who are undocumented, may have DACA status. And what this bill does is really expand coverage for this population and it is being administered, the coverage for the services, through the statewide network of reproductive health program clinics. And some of the services that are outlined as being covered in the bill, and the bill really is sort of a very long list of preventative reproductive health services, and sort of group them in kind of the larger buckets. So the services include a broad range of contraception and contraceptive related services, including counseling, and this includes LARCs, long-acting reversible contraception, well woman visits, screening for pregnancy and sexually transmitted infections, and counseling on preventative health services, including STIs, relationship safety, and tobacco use. In addition to these services, outpatient abortion services are also included in the coverage, and because there are a more limited set of abortion providers, and this service isn't widely available through the statewide network of reproductive health clinics, program clinics, there is sort of a subset of clinics providing this service. And I'll provide some information about how clients can learn about where these providers are.
Emily?
Yes.
This is Leslie, and I would just like to say one thing about our network of programs, the Reproductive Health Program Clinics. One of the reasons that it makes sense to build these services, this provision of the bill, into our program, the Reproductive Health Program, is because we have provided services for this population for many years, for over 40 years, as a matter of fact, through our Title X federal grant for family planning services. Now, those did not include abortion services because it is a federal grant, and we did not provide sterilization services for women, but we have been, those services have been available at our clinic, the other reproductive health services. It's just that the Title X grant was so small, has been traditionally, that it hasn't, we've not had the capacity to serve everybody who needed or wanted our services, or necessarily to even reach out to let those who might be interested in using our services that they are available. So this is an expansion. The RIA legislation is enabling us to expand our services to reach more individuals that we had already been serving, and with more services.
Thank you. That's a great clarification. It's actually a perfect segue into the next slide, because as Leslie said, we've been around for about 40 years, and we first started with Title X funding, which is the sole federal grant program for family planning services. And then about 20 years ago, applied for and received approval for a family planning Medicaid waiver, which used to be called FPEP, and for the last about 10 years has been called Oregon Contraceptive Care. And this Medicaid waiver kind of expanded upon the Title X funding, which, as Leslie said, has really been a support for family planning services for low-income Oregonians who didn't have necessarily access to or eligibility for coverage for reproductive health from other sources. And so what I'm going to do is kind of back away a little bit from the REA specific services, because as Leslie mentioned, REA really served as an expansion of coverage for clients accessing services through our program. And I want to touch a little bit upon the RH program hallmarks. We support a diverse network of providers who help Oregonians achieve lifelong health and live productive lives. we contribute to the achievement of equitable health outcomes for all populations in our communities. And that's sort of accomplished by ensuring that all Oregonians have access to high quality, low cost, client centered, confidential RH services where, when, and in the manner in which they are needed. And I think what really sets our program apart from sort of more conventional payer sources is that our program is really based on high quality, evidence-based care that assures not only coverage for these services, but that the services are of a high quality. And so the RH program provides access to these services not only to the population described in the bill for RHEA, which is individuals who can become pregnant who would otherwise be eligible for medical assistance if not for their immigration status, but our clinics serve all low-income individuals of reproductive capacity regardless of their citizenship or immigration status, sex, gender identity, and residency. And I want to make a little plug that includes vasectomy services. Because vasectomy services are not included in the provision of RHEA that expands coverage for individuals who can become pregnant. And so we do have other sources of funding that supports vasectomy services. So where and how would a client access the services provided through the network of RH program providers? So there is, as I mentioned, it's a statewide network of clinics, including many of the local county health departments, Planned Parenthood clinics, federally qualified health centers, and other community-based health centers. And unlike sort of the OHP application, clients seeking services, so clients not already enrolled in OHP, can complete on-site a client enrollment form and receive access to same-day services and supplies. And again, clients don't have to complete an OHP application. If a client is already enrolled in OHP, they can still access services at our clinics. All of our providers are enrolled as OHP providers. Our providers can also serve individuals with private health insurance. But for those who don't already have a source of coverage, if they meet income criteria, then they can enroll at the clinic and receive same-day services. And the best ways for you all and for clients and community members to learn who the network is to either visit our website or call 211 for the complete listing of clinics. I'm not sure if I don't think my previous slides indicated we have about 150 clinics around the state. So it's a pretty expansive network. So I kind of want to summarize here what we've just been talking about, because I know we covered kind of different services for different populations, and I want to make sure that that you all have a clear understanding. So we started with talking about pregnant women enrolled in Cowan Plus, and that starting April 1st, these women have access to 60-day postpartum medical care, including dental, immediate IUD, implant, and female sterilization. And again, this is available for any woman enrolled in Cowan Plus regardless of how the pregnancy ended. And providers would bill for these services in the same way they do for women in the prenatal period. The next sort of population and set of services we talked about, actually I'm skipping a little bit. I'm actually going to go to the very bottom row, so I'm going a little bit out of order, but this kind of would reflect how I talked about it in the slides. So we also talked about individuals who can become pregnant and are ineligible for OHP because of their immigration status. And they have access both to inpatient abortion services and female sterilization. So again, for female sterilization, this is for women outside of the 60-day postpartum period. And individuals who are seeking or needing either of these services would need to complete the OHP application and be eligible and have coverage under either COWM or COWM Plus. And again, facilities and providers and hospitals would bill for these services in the same way they do for COWM and COWM Plus. And then we talked a little bit about services that are offered through the Reproductive Health Program provider network or clinic network. And these services under RHEA is an expansion of coverage for individuals who can become pregnant and who are ineligible for OHP because of immigration status. And it was a pretty broad range of reproductive health services. And as kind of Leslie mentioned and I talked about, these broad suite of reproductive health services are available to any individual coming into one of the clinics, regardless of immigration or citizenship status. And those services are available through providers enrolled through our program. And as a reminder, we've been focusing a lot on changes due to RHEA, and for those who have been previously ineligible for coverage, all of these services have and continue to be covered under OHP and the newly passed legislation SB 558, which expands OHP benefits to kids under 19 who would otherwise be eligible for Medicaid if not for their immigration status. And so as a reminder, OHP covers family planning visits, birth control, sterilization services, women's well woman visits, pregnancy screening, and screening for STDs. And this kind of, I think, underscores what I began with, which is really there is a patchwork of coverage sources. And RHEA was really meant to establish parity between or among those who aren't eligible for OHP. So I'm going to stop here. This is Leslie's dog, Zoe, I just noticed whose paws are kind of cut off in the picture, but she's so cute, I don't think it matters. So do we have any other questions at this point? Okay. So I'm going to pass it along to Leslie. I'm going to ask Colette, do I need to advance the slides for Leslie, or does she have the ability to do that?
So we would advance the slides unless Leslie has them up on her screen at this stage. So we could very well just advance them for you. Does that work for you, Leslie?
It does, and I'll let you know to advance. That would be helpful. Thank you.
And we did, and just before I advance, we did get one question asking us to reiterate what is the best way to find a list of reproductive health providers. So you have a couple of options, and we will, at the end of the slide deck, have our contact information, including our website, and there's a link to find a clinic. The other way is to call 211, and they have a complete listing of our clinics. Okay, so Les, here you go.
Thank you. Thank you, Emily. That was great. You know, Zoe's paws aren't necessarily her best feature, right? So we have a portrait shot. So I would like to turn now and talk a little bit about issues to consider. And these are issues that have been coming up within our discussions and meetings with across the division and the agency, issues that we are uncovering as we were planning for implementation, and also raised by community members either during regional forums that we have done or other sort of community listening sessions. And so I'll just go through these. The other way that we're thinking about these issues that have been raised is, they are challenges, issues, but they are also opportunities. So we'll kind of go through. I think the one at the very top of the list, and rightfully so, are concerns about immigration status and data privacy. And that is something that has come from everyone we've talked to, and that we're well aware of, community members, providers, community partners. And that is something that we are very acutely aware of, and we have been working closely with Colette and your team, and with our agency's Department of Justice, and to figure out how we can protect the privacy of the data, and how we can reassure, most importantly, the community members that our clinics are safe, that we do provide the confidential services, protect their privacy, and also to sort of look at how we can minimize the amount of data, the information that we collect, to really look at collecting the minimum amount we need to be able to provide the services, and to fund the services without collecting more than we need. So that, I think, is just going to, and it's heightened now too because of the political environment, of course, in the United States right now. So we are that's a work in progress. So stay tuned. And we will be sharing information both with you and with our providers and our community members as we figure this out. Emily or Colette, did you want to add anything to that?
No, I don't think so.
Okay, thanks. So the next one is that Medicaid and the reproductive health program recipients are not considered public charge, and enrolling for coverage will not affect the immigration process. And again, the public charge refers to a person who is considered primarily dependent on the government for subsistence, such as receipt, demonstrated by receipt of public cash assistance for income, maintenance, or institutionalization for long-term care, or other services like that at the government expense. And that has a particular implication for immigrants. And so we would like to emphasize that for the purpose of our programs, those services are not considered part of those services that would designate someone a public charge to the government. And I understand that there is a public charge document on group site that has more information that we would refer you to for that. Another one is just navigation of new services that are provided through this the REA legislation. And these services are new for us because we haven't provided them directly before. We have, as Emily mentioned, male sterilization or vasectomy services we've been doing for nearly 10 years now. So that is something that we've worked really hard to find providers that we could contract with, or that our provider network could contract with to offer that service. But we have not up until now had the capacity or the funding to offer the sterilization or abortion or mammography, particularly the abortion, because of the prohibition of our ability to use federal funds to pay for abortion services. So the challenge for us is finding providers that we could either contract with or that are within our network, and there aren't that many. As Emily pointed out with abortion providers, we're starting out with a handful, and we're looking to expand the providers to bring them into our network for abortion services and similarly for sterilization. But right now, that's the opportunity for us, right, is to figure out ways to either build capacity within our network or contract or work with other providers of those services to make those available. But so that's just, it's new to us. Information, referral, and coordination across programs. I think that to Emily's point earlier, two things. One is this is a huge bill, REA. It's really comprehensive, many provisions, and there are different agencies or different programs that are responsible for implementing the different provisions. So that could create sort of add to the fragmentation between the different programs and provisions of the bill. That's the challenge. The opportunity is for us to work across the programs, across the agencies, to break down our silos and to try to take that patchwork and streamline it a little bit more, and to, in terms of the fragmentation, to sort of weave it together so that from the client's perspective, it doesn't feel fragmented. I mean, I think this might be our ultimate goal is for the client, it's all streamlined. It doesn't feel fragmented or patchwork. They can get the services they need, and depending on what let's say, for example, the 60-day postpartum period ends, they can still be eligible for the full reproductive health services, preventive services that we offer, and so that they still have services that are essential health services that are available to them. And so our task is to try to make that as seamless and as easy as possible for our clients. But we are continuing always in communication. We have interagency communication work groups to ensure that we're coordinating our messaging and our processes for providing information and referral. And we will you're a big piece of that, a big part of that network. So we definitely need you to be a part of that with us and invite you to join in on that with us. Excuse me. The cultural and linguistic responsiveness, particularly around language access, but not solely, that is always can you still hear me?
Yes.
Okay, sorry, I just heard a loud beeping in my ear. So that's something we're always working on. We've always been working on that. That's a real work in progress, maybe sort of like a continuous quality improvement. And now, of course, especially with this expanded services for these communities, it has heightened the need to really step up our efforts in this area. And I should say this is something that we are very keen to, not only for our provider network who are on the front lines providing the direct services, but also for our program staff at the state level. So looking at this both from sort of a systemic or systems point of view of how we can be more responsive when we're making our policies and our program certifications and the processes that we use and the materials or tools that we provide to support our provider network, and then also working directly with our providers. And then the same thing, client privacy and confidentiality, and particularly in small and rural communities. This is always something that can be a challenge in rural communities where everybody knows everybody. And if you see a neighbor take their adolescent son or daughter to a clinic, the community can talk about why are they going to the clinic and what's up, and we hear about this a lot. And I think that our providers are particularly good at trying to ensure privacy and confidentiality in a way that is especially for everyone, all of the clients that walk through the door, but I think in the past this has been particularly acute for youth using services, and also for these our newly expanded community members that will be able to serve the immigrant communities. And again, we are aware of this. We're continually working on this, and we are always open to feedback on how we can do it better, both at our level, at the state level, and most importantly at the our local provider level. So could you advance the slide, please?
Yeah, and I just wanted to jump in again and kind of reiterate what Leslie said much more eloquently than I did, which is, I know I focused a lot about sort of the fragmentation or sort of the patchwork, but I think as Leslie mentioned, and I just wanted to underscore it, our goal is really to create as streamlined of sort of coverage and access for individuals as possible. And it really has, been an opportunity for us to work across programs within the Oregon Health Authority and with other community partners and community members to ensure, and because most importantly, from the client perspective, that wherever they walk in the door, sort of wherever they are in their kind of reproductive health needs, that they're getting the service they need. So I wanted to reiterate that and sort of wanted, to appreciate how Leslie described it. So I'll move on now.
So we worked with a couple of regional health equity coalitions last summer and asked them to go into their communities, the immigrant communities, to talk about their experiences accessing reproductive health services in particular and some of their concerns, and just to show how they reflect on these, in particular around immigration. These are very common sentiments. One says, I think that whenever you have to go somewhere that you sign forms, you're scared if you're not legal, no matter what. Or when you go to the clinic, they always ask your information, name, where do you live? And I believe that the excess of information is something that intimidates people for those without papers. And so we know this, and again, we are working very hard to try to help people who come through our door, no matter what, feel comfortable and safe, that our clinics are a safe place to go, and explain exactly why we're collecting the information we collect, why we need it, and what we do with that information. So just a couple of examples, and then I have one more if you could advance the slide, please. And this one relates sort of to the language access. Sometimes you understand a little because you know some English, so you tell something to the interpreter and you realize that the interpreter is translating wrongly. Yikes. Another one shared that I've been in a few situations where my mom comes home and I'm like, how'd it go? She's like, there was a translator and I don't think she told me right, or I don't think they understood me. There are lots of stories around this, and the language interpretation services that are available in our clinics, as you know, that all of our clinics have to provide language interpretation services for free in the language that the client needs or wants, and we provide that they need to be notified. We should be notifying all of our clients that that is a service that is available to them, and it's available to them without cost. And we do know that different of our providers have different ways of doing this. Some have hired, they have bicultural, bilingual staff that interpret in the exam rooms or interpret for clients in a variety of situations. Some of them have providers who are bilingual and or bicultural. Some also hire hire language interpreters or they have a contract that will come in when they have appointments where they know they're going to need an interpreter. Others use the AT&T language line. So there's a variety of ways, but there's still a lot of barriers for our clients, and it's definitely not a smooth running, well-oiled machine the way that we're able to offer these services. And so that is a real high priority for our program right now, and we are working with the Office of Equity and Inclusion, and we're working with our local provider network to see how we at the state level can help address that and strengthen and build their capacity to provide high quality language interpretation services. So could we go to the next slide? So this is the point where we want to ask you, what do we need to know? We think we have things that we want to know, but we really need to hear from you. Talk about being in the front lines and working directly with the community members. You are a great connection for us. Tell us what you need. Just some things like, who should we be connecting with? I have here, what are the best ways to reach your clients? But really, they're our clients. We're serving the same communities, the same families. They're our clients too. So not just yours, but you've been doing this for a long time. You've been out there, even more engaged in the community. So what can you share with us? Thinking back about the care coordination or referral, what is your message if you're working with youth and they are, when they turn 19 and they age out of being able to be covered by OHP, now covers me or covers all kids, do they understand that they could still, if they would like or need, access free reproductive health services? Is anybody messaging that to them if they get an enrollment letter or some sort of notice, or when you're out talking with them? Opportunities. What are some opportunities that you see for us and or our provider networks and how we could partner together? And I realize that some of you probably are part of our provider network already. So, how can we do even better and partner? What are you hearing from your clients? Just anything that you think we ought to know. We would be very curious to hear from you. We need to hear from you. So I don't know, Colette, if the best way now is to unmute or have folks raise their hands or type in the chat box.
Yeah, so anyone who wants to chime in, you can actually take yourself off of mute by just pressing *6. So feel free to chime in by pressing *6, and then you should be able to speak and we should all be able to hear you. And if you don't have that option, you can also type feedback answers to these questions into the chat box, but feel free to chime in now.
And certainly this isn't the only time. We want to hear from you whenever and however you want us to hear from you. So we'll have some contact information at the end of the slide. You're always welcome to email our office, to give us a call, or to go through Colette, or however, to let us know if you have ideas, or if you've uncovered other things that you think. Do you have ideas for opportunities, or you're hearing things from community members or your clients that you feel like we ought to know? Okay, and shall we go to the next slide? Emily, did you have anything?
No.
That you wanted to?
Oh, I think, some questions just came in to the chat box. So we had a comment, where a participant said a couple of things I have seen is they don't understand, they need to renew every year, and immigrants like to work with Spanish speaking face to face. Thank you for that. That is great feedback. The next comment was someone who is looking for more resources to provide to our providers about sterilization services now being covered by CALM. And that's great feedback as well. And that's an area where we know that we need to do more messaging and reaching out to providers about that, the availability and coverage of that service specifically. So thank you for that feedback.
Right, absolutely.
And it looks like that's it thus far.
Okay, great. All right, well, so here are just some ways that you can stay updated and get more information. I think we mentioned this in our first webinar back in December, but we do have a bi-monthly email update that we send out that just gives updates on where we're at with implementation or availability of materials or availability. We call for folks who want to join us on a work group or help us figure out something. They're just usually, it's an email and a couple of bullets with updates. And if you would like to sign up for that, you can just email us or, pardon me, as I mentioned, you could let Colette know, and we'll add you to our distribution list. We do collect, and again, this is another work in progress, frequently asked questions. We have a document in English and Spanish for general information, and we always add to that every time we go out to the community or do presentations like this, and we get good questions, we add to it. So we have that available. And that, Emily, have we put that on the group site yet? Do you remember?
I think we have a kind of array of information, sort of one pager, but we will, I think it's a good reminder that we should be sharing with Colette sort of documents as we kind of finalize those to share on the group site. So we will sort of commit to making sure that various resources are available on group site as they're being developed and refined.
Yes, thank you. We do also have more materials for what we call referring providers, community-based organizations serving the same populations and clients that'll be coming soon. And we, some of you recently perhaps helped give us feedback on some client materials that we are back now in our publications department, and those will be available very soon. And we have some other materials, sort of pathways to care for community-based organizations or other providers of other services who might has information for referring their clients. That will be available at the end of the month, and we will definitely put those up on group site and let you know when those are available. We also have a web page. We have a website. The Reproductive Health Program has a whole website, but we have a page on the website specific to the Reproductive Health Equity Act that has more information. And as materials and information becomes available, we'll continue to populate that page. So if you don't see what you need, check back later or shoot us an email. And we also have information about becoming a certified reproductive health program provider. So these are the certification and application pages, and you could see the standards of what we require for someone to become a certified provider in our network to offer these services. And so if you're just curious about what it would entail to become an RH program provider or what our standards are, you can go take a peek at those documents. And certainly if you're not already a reproductive health program provider and you would like to become one or to consider, you can go to that page and get more information about that. And I guess that was one of my other things. If you have suggestions for other access points out in the community, either suggestions for other providers or potential providers that we could invite to join into our network, please let us know. And other access points just for information or for being able to go to where community members are, like places of employment, or have where we could work with community health workers or health navigators or our local outreach workers. Let us know. We'd be interested in that as well. And then I guess the last slide, our web page there, that gives that's our RH, our main program web page, where you can find out information about all of our whole entire program. We have the one page on our website specific to the Reproductive Health Equity Act. There's our email. You can email us if you would like to subscribe to the biweekly email updates or have any questions or suggestions, or call us directly at our phone number, 971-673-0355. And I think that's all I have. And if you, Emily or Colette, you would like to add anything more, but I would just like to say thank you for this opportunity. Thank you for joining us and allowing us to sort of update you. And I think, our not so hidden agenda here too was to ask you for ideas and ask you for some input on how we can do even better. So thank you very much.
Give me the phone number. Hello?
The phone number is,
971.
yep, it's 971-673-0355.
0355.
Yes.
Okay, thank you.
And we just got in some questions specifically around the requirement in the Reproductive Health Equity Act around private insurer coverage of preventative reproductive health services with no cost sharing. The first question was, do we know how it will work as of next January for private insurers? I don't have specific, or I don't have great answers for you, just because that the private insurance plans are regulated under a different state agency, the Department of Consumer and Business Services, although we've made some great connections with them. And I think it's our intent to better understand the answers to those questions as we get closer to January 2019. I think primarily it just means that individuals who have private insurance coverage in Oregon will now be assured that there are no cost sharing requirements with those services. And for many insured, those benefits are already available, right? I mean, so the ACA had a long list of preventative health services that insurers were required to cover without cost sharing. In January of 19, abortion will be included, as well as vasectomy services for men. But I think for many individuals, they may not see a change at all. Another question was, does the law only apply to Oregon insurers or those based in other states? And my understanding, and again, I would refer to the Department of Business and Consumer and Business Services, is that it is insurance plans regulated by the state of Oregon. So I think, simply those based in Oregon. And there was sort of a clarifying question around that. Does Cigna have to follow the law and allow the no-cost share for vasectomies, even though they aren't based in Oregon? And this is where my knowledge really starts to falter. But if Cigna has a plan here that's regulated by the state of Oregon and DCBS, I would assume that they would be required to cover vasectomies. But we will do some more research about that, and we'll reach out to DCBS and try to get some clarification. And I know that when we did the last webinar with Colette, there were a number of questions, and we typed up answers and sent those out. So we will try to do the same and get you the clarity that you need. I have to advance to the next slide just to give Mango his final. I told you he likes to sleep wherever and whenever he can, including my side of the bed. Do we have other questions or comments or feedback? I mean, we're using these opportunities to get information out to you, but also to get your feedback. I mean, that's really one of our big goals in all of this.
And I would say many of you have been really great about emailing in your questions in general as they come up with your different clients, so please continue to do that. Every question I get from you all, I share over with Emily and Leslie as well, so please continue to do that. Leslie, any other thoughts or questions?
No, just again, just thank you for the opportunity, and look forward to hearing from you.
Yeah, and I just want to say thank you to you both, Leslie and Emily. This partnership has been wonderful for our team, and we really appreciate all of the information. I know our partners really appreciate it as well, so thank you guys so much.
Thank you.
We will send the slides out. We got a few questions about that. We will definitely send these slides out to everyone who registered. So be looking for those in the next day or two, and continue sharing with us any questions or concerns that come out or come up around any of these topics. And we look forward to continuing to work with you guys on this.
Thank you.
Absolutely. Thank you.
All right, you guys, thank you. We are signing off. Have a great rest of your day.